Most of the work I've done actually started from Cedars-Sinai Medical Center. That's when I was served on faculty between 92 and 2007. I then went to IU and continued this work. I'm very fortunate to be able to come back to Cedars and continue with the studies on the neuromechanisms of cardiac arrhythmia and the mechanism of neuromodulation. What I hope to accomplish today is to review briefly the history of neuroplasticity, namely the nervous system can remodel itself, and then followed by how to use that property to control cardiac arrhythmia. I have some very long-term collaborators, and on the left, who has been collaborating since 1990s. And on the right side is my current team, including Corinne Rosenberg and Amy Liu. So the story really starts many years ago when Dr. Montalcini of Italy discovered the nerve growth factor and won the Nobel Prize. And then for the heart, in 1991, there's this paper on S100 protein stain of human myocardium after myocardial infarction. This staining, S100 stains for the Schwann cells. After myocardial infarction, you can see the nerve stains black, and they have a large amount of nerve growing as compared to baseline, which is it's hard. Sometimes it's difficult to even discover these nerves. So that discovery led us to think that it is possible that if there are so many nerves, it might be playing a role in cardiac arrhythmogenesis. So we did this work. It was done by Dr. Cao, who is currently a professor and running his own research institute in China. But this is in the late 1990s when he was my fellow. We have done a study in dogs in order to produce the primary or major substrate for ventricular arrhythmia. We have created a myocardial infarction and a complete heart block in this dog. But then we have two groups of dogs. One group, we infuse the nerve growth factor, or NGF, to the stellate ganglion. This is the experimental group. Another 6 dogs with MI and complete AV block without nerve growth factor infusion and serve as controls. And it turned out the former group has a very high incidence of sudden cardiac death. These are spontaneous sudden cardiac deaths without electrical stimulation. This is the findings in the heart. This is actually a normal ventricle. And we, not in this particular study, but in the previous study, we have documented the fact that nerve sprouting and sympathetic hyperinnervation can occur after NGF infusion into the stellate ganglion. So these are several different stainings. Tyrosine hydroxylase, tyrosine hydroxylase or TH stains for sympathetic nerves, synaptophysin and stains for nerve structure in general, and GAP43 is growth associated protein 43, which stains for the growing nerves. And it's clear that after NGF infusion in the stellate ganglion, the heart has plenty of nerve sprouting and also sympathetic hyperinnervation. This is even in the normal ventricles. So with myocardial infarction plus AV block, we have additional nerve sprouting in the heart. And these are the 4 dogs that died. This is a dog number 2 and day 11 at 10 o'clock. And I believe this dog is probably the death was witnessed because the technician was trying to feed this dog at about that time. And dog just dropped dead. And another dog got dead in the afternoon, early afternoon, and early morning. And there are also another dog which has a non-sustained VF, right here. It looks like torsade, but it's a ventricular arrhythmia. You can also see in this study that there was background P waves. So these dogs has not only have myocardial infarction, but also has complete heart block. So in comparison, the control group actually, those dogs did not die. So there's a significant difference between the experimental control group. So the conclusion is that if you give more nerve growth factor to the static ganglion to encourage cardiac nerve sprouting, then this dog has a high instance of ventricular fibrillation. So the implication is that if you have the ability to inhibit those nerve sprouting, then these dogs probably have less of a lower instance of sudden death. So that brings a hope that doing neuromodulation might be an approach to prevent sudden cardiac death and cardiac arrhythmia. So we took this concept to humans. So at the time, there are still, instead of a catheter ablation of ventricular tachycardia or fibrillation, we have been taking patients with ventricular tachycardia to the operating room and excise the source of the VT after computerized cardiac mapping. So after mapping, we decided where the ventricular tachycardia come from. We take them out. And you can see on those tissue blocks, there is a large number of nerves at the source of ventricular tachycardia. And you can also see over here, this is a myocardial infarction, and this is a myocardium, and this is infarcting myocardium with round cell infiltration. According to my pathologist, this indicates about the 2 weeks of myocardial infarction, which is consistent with the history that this patient actually underwent cardiac transplantation for the incessant ventricular arrhythmia. You can see all these nerves are growing from the myocardium into the, trying to reinnervate the dead tissue. So that supports the fact that at the source of ventricular arrhythmias, there is increased cardiac nerve sprouting. So it's consistent with the hypothesis. We subsequently did a manuscript by Dr. Zhou, who has created a myocardial infarction. Then instead of looking at only looking at the heart, she also looked at the static ganglion. So in the infarcted site versus non-infarcted site of left ventricular free wall, you can see there are significant increased messenger RNA of NGF and over gap DH ratio. So nerve growth factor is immediately overexpressed as fast as 3.5 hours after myocardial infarction. And say this is a myocardial, this is actually Dr. Richard Verrier very kindly wrote editorial and provided this figure. This is site of myocardial infarction. What happens is immediately after myocardial infarction, there is overexpression of nerve growth factor. No nerve growth factor then go backwards through a process called the retrograde axonal transport. So retrograde axonal transport would transport this nerve growth factor back into the static ganglion, causes the static ganglion to get a signal and start to produce nerve sprouts and hyperinnervate the heart. What is important is that it not only hyperinnervate the ventricle near the infarct site, it also hyperinnervate the atrium. And we have another paper documenting that fact. So after myocardial infarction, you can have hyperinnervation throughout the heart, not just at the site of myocardial infarction. And that results in increased myocardial contraction to keep the patient alive, but it also increases the incidence of cardiac arrhythmia. With our dog model, we subsequently recorded directly the stellate ganglion nerve activity and subcutaneous nerve activity. the nerve under the skin on the thorax came directly from the stellate ganglion. Therefore, if we have shown the subcutaneous nerve activity is a reflection of the stellate ganglion nerve activity. And in this particular dog, this is continuous tracing. There was continuous hyperactivating nerves. And at the time of ventricular fibrillation onset, there was the nerve discharge. Nerve discharge actually preceded or comes before the actual occurrence of VF. And after VF, there was a massive discharge of the nerves, both in the stellate ganglion and in subcutaneous tissue. We hypothesize this is because the dog has collapsed with no blood pressure, and this is the dog's way to try to compensate for the loss of blood pressure. There is another coincidental occurrence that I want to mention, although I can't prove that it is actually the case, is that this large sympathetic discharge roughly occurs at the time of transition from VT to VF. So from the onset of VF over here, the morphology actually looks more like VT, and this is so-called the Wiggers stage 1 VT. This VT is formed by rotors or spiral waves. And when the massive sympathetic discharge occurs, the spiral wave breaks down into fine multiple wavelet, multiple spiral wave ventricular fibrillation. Timing-wise, there is a coincidental occurrence. So this secondary large sympathetic discharge contributes to the VT and VF transition. That's a hypothesis anyway. So the idea is the neuromodulation methods that reduces stellate ganglion nerve discharge may be anti-arrhythmic. So stellate ganglion is a source of arrhythmia. Stellate ganglion is generally formed by C8 and T1, which is a major source of innervation, both in the atrium and in the ventricle. And the stellate ganglion nerve activity precedes the onset of spontaneous cardiac arrhythmia, including ventricular fibrillation and the sudden cardiac death, as I've shown in the previous figure. So I will show later that the stellectomy is used to treat patients with long QT syndrome, CPVT. This actually, this knowledge that people think stellate ganglion is important in cardiac arrhythmogenesis was present for almost 50 to 100 years. In 1971, Dr. Arthur Moss took a patient with long QT syndrome to the OR and cut out the stellate ganglion. And the patient is still alive, as when I last saw Dr. Moss. And the patient back in 2007 and has no ICD discharges. So currently, according to the guideline for patients with long QT syndrome and CPVT, the stellectomy is used to treat these patients as a documented indication. By the way, Dr. Arthur Welde of Netherlands was a person who provided the data that supports the use of stellectomy in treating CPVT, or catecholaminergic polymorphic ventricular tachycardia. So stellate ganglion, again, is a very important target for neuromodulation. The problem is stellate ganglion is very difficult to reach because it's in the back of the thorax near the spinal cord. Obviously, if you talk with Dr. Welde or Dr. Peter Schwartz of Italy, they would say that they have good surgeons who can access it. If you talk about the Mayo, people in Mayo Clinic, Dr. Ackerman's group, they said they can do endoscopic stellectomy for patients with long QT. However, a surgical procedure is expensive, and there are a lot of people who have atrial or ventricular arrhythmias. So perhaps if we can find a better way to remodel or damage the stellate ganglion, we could control atrial arrhythmia. So one way to perform neuromodulation is rapid electrical stimulation. So this is a study we performed that back in 2000. Actually, there was another one slightly earlier, where we got a donation, very kindly donation from a maker of the vagal nerve stimulator. So vagal nerve stimulator is a stimulator that is currently used for remodeling of the brain and control intractable seizure disorder. And that has been approved by FDA in the early 1990s. And there are over 100 and 200,000 people have had this device implanted on their vagal nerve. So they have an FDA approved device. This is a wire coming in. And here's the anchor, which has no electricity, but there are electrodes here. See this white, this metal, these are the electrode. And the negative pole toward the brain, and the positive pole toward the chest. And this is the vagal nerve in the neck. Obviously, in humans, the implantation has to be done by a very experienced surgeon so as not to damage this nerve structure or the surrounding carotid artery. But for dogs, we were able to implant it using this device. It's not all that difficult. So left cervical vagal nerve, we put it on here and we stimulate the vagal nerve. And we want to see what happens to the nerves. I will tell you why I think that way a little later. So you just remember that we can implant a vagal nerve stimulator in the dogs. And the reason why we thought that might be useful is that back in 1983 from Washington University, St. Louis, Dr. John Oni is a pathologist over there. And he did a study on neuronal cell deaths induced by rapid electrical stimulation of the axon. So it's a rat study with 14 rats, 2 to 20 hertz of electrical stimulation for 24 hours. He stimulated the axon of the peripheral path, which is has a lot of axons of the nerves that goes to the brain. And after he was done, he discovered two things. One is that these rats have seizure disorder. And number two, there is a cell death in the central nervous system. This is on the right side, the electron microscopic picture. And you can see these nuclei, which is pycnotic, very dense, indicating the cell probably have died. And there are multiple these abnormal findings. And he found, as a pathologist, he found that this is a stain of the pyramidal neurons, which connects to the peripheral path. After 24 hours, intermittent peripheral path stimulation. He found that the histological findings shown on the right closely resemble the excitotoxic type of damage that the putative transmitters glutamate and aspartate are known to cause. Now, let me explain this sentence. Excitotoxicity is a phenomenon that occurs in the brain where the glutamate, which is a neurotransmitter, is released from the dead cells. And that released neurotransmitter affects its neighboring cells, which continue to be excited. So the intracellular calcium accumulation due to repeated excitement, that cell dies as well. And this will propagate slowly. And this is one of the mechanisms of Alzheimer's disease. And the glutamate receptor blocker is FDA approved to treat as one of the currently available several drugs to treat Alzheimer's disease. So these are, at the time, people already discovered there is such a thing called excitotoxicity caused by these neurotransmitters. But what he discovered is rapid electrical stimulation of the axon can cause the neuron to also die, looking like what happened to the excitotoxicity. The process is probably the same. You excite the neuron, the axon, and excite the neuron, which continue to be excited, and results in the neuron to die. So the idea is that if you stimulate axon, you can then inhibit the, you can then cause remodeling of the neuron itself and achieve the purpose of neuromodulation. Now let's come back to the vagal nerve. This is a important picture for medical student because in medical school, they teach me vagal effect, as if vagal nerve only contains parasympathetic nerve. It is true that the vagal nerve contains parasympathetic nerve, and it's one of its main function is to communicate the vagal nerve parasympathetic signal to the heart and to the rest of the body, especially the GI tract. However, if you do a cross-section of the canine vagal nerve, this is a luxo-fast blue stain, which stains myelin. They are both myelinated nerve fibers and unmyelinated nerve fibers. Post-ganglionic sympathetic fibers are unmyelinated. So these unmyelinated nerve fibers matches with tyrosine hydroxylase positivity. So these are sympathetic nerves, not parasympathetic nerves. But if you stain for choline acetylesterase, which stands for the acetylcholine transmitters enzyme, you will also see parasympathetic nerves roughly distributed similarly to the sympathetic nerve. Now, trichrome stain would have a lot of positivity here. You can see all these nerves have a very high fat content, so that's why there is a little whitish tissue around the axons. So what are these nerves? Well, these nerves, many of them are sensory nerves. Some of them motor nerves, were very well myelinated motor nerves that go through the vagal nerve and going into the recurrent pharyngeal nerve and control the motion of the throat. So these are complex structures. So when you do electrical stimulation, you not only stimulate the sympathetic vagal nerve, you also stimulate the sympathetic nerve. And we took the dogs with vagal stimulation out, and we took a low power picture. So if you do histopathology study, don't go straight to 40 to 40 times of magnification on the objective. Sometimes 2 times magnification, like this one, 1.5 or 2 times the magnification will give you more story about the whole picture of the section. And you can see quite clearly the right side looks more normal with tyrosine hydroxylase stain with individual nerves. Neurons have tyrosine hydroxylase. On the left side, the cell are dead. Now, these are the stellate ganglion that has undergone vagal nerve stimulation for several weeks. And vagal nerve stimulation has additional effect I'm not going to show, but it does reduce the stellate ganglion nerve activity. It does reduce the cardiac arrhythmia. It does control the ventricular rate during atrial fibrillation. So vagal nerve stimulation is a potential anti-arrhythmic drug approach to control human arrhythmia. The previous clinical trial in heart failure has excluded all 3 major clinical trials. Heart failure has excluded patient with atrial fibrillation in the vagal nerve stimulation trial, and has no effects on heart failure. I think it's a mistake. I think those trials, had they recruited just patients with atrial fibrillation, they might improve the ventricular rate and improve the heart failure, as I will show a little later. Now, can we find a nerve axon that's connected to the stellate ganglion and is easily accessible? Well, we discovered this paper. I want to thank Dr. Anisha Deutsch-Nova, who discovered this paper for me, that was published in 1994 in Journal Anesthesia. The hypothesis is the author injected tracer into subcutaneous tissue, and they find that the tracer injected near the neck or the upper thorax goes primarily into the stellate ganglion. Tracer injected elsewhere also go into the stellate ganglion, but to the less extent. But this is important. Stellate ganglion actually innervates widely, not only here, but also inside, like in the kidney. That will be important later in the talk. So we hypothesized the rapid subcutaneous nerve stimulation can damage the stellate ganglion, reduce sympathetic outflow, and control cardiac arrhythmia. So we look for the nerves, and we look for the Chinese acupuncture literature, and there turned out to be acupoint in dogs. And this one is called Xin Shu. The reason I chose Xin Shu is because in old Chinese literature, Xin Shu calms heart by acupuncture in this point. So the first dog study, actually, we look for the nerves in over here. Subsequently, we did a 3 study, and we're just randomly looking anywhere under the skin. So there is no evidence that the acupoint is in any way different than other parts of the subcutaneous tissue. Sometimes you'll find a pretty large lateral thoracic nerve with wrapped vagal nerve stimulator onto it. That was done by Yuan Yuan and Zhao Lei, very good postdocs. And also by Kusayama. So I have about 3 fellows doing about the same projects on various kinds of cardiac arrhythmias. And we hypothesize that we don't need to identify the nerves. We can just blindly insert an electrode under the skin. So we cut it open for device implantation. Then we just blindly insert this electrode under the skin without looking for the nerves and do subcutaneous nerve stimulation. It turned out to be quite interesting. So this is without stimulation. This is static ganglion nerve activity, subcutaneous nerve activity. They fire about the same time, obviously of different magnitude, different amplitude, because the static ganglion is much larger. And in these dogs, when there is spontaneous nerve activity occurring, there is massive increase of heart rate. So baseline, there was respiratory variation of heart rate, respiratory variation. But during the tachycardia, there is no respiratory variation of the heart rate corresponding to the nerve activity. And over here, you can see there is a respiratory variation of the heart rate that ties into the sympathetic discharge. Finally, on the right side, when the subcutaneous nerve stimulation come on with these artifacts, you can see that you abruptly interrupted the static ganglion nerve activity. And also there was evidence, there are some recordings that you can record from the vagal nerve. So subcutaneous nerve activity causes abrupt interruption of static ganglion nerve activity, reduces heart rate as compared to a baseline. So when we see this, we know that there is direct communication between the subcutaneous nerve in the thorax and the static ganglion, as has been previously reported. And on the static ganglion, after about several weeks of stimulation, we take them out and then do a simple stain with trichrome. You can see that depends on the intensity of the stimulation. The dog is prospectively randomized into sham control 0.25 and the 3.5 milliamp group. With 3.25 milliamp group, there was clearly increased fibrosis inside static ganglion. But we found another interesting thing we so far has not been able to explain is that there was a difference between male dogs and the female dogs in its response to the static ganglion stimulation, to the subcutaneous nerve stimulation. The male dogs has more fibrosis in the static ganglion, but all of them have more fibrosis with a stronger stimulation than lesser degree of stimulation. But their effects on the nerve activity did not differ. And these studies show the randomly inserted subcutaneous electrode will be able to remodel the static ganglion. And we are starting a clinical trial in humans to test that hypothesis under the support by the National Institutes of Health. This is another thing that is interesting. In Kusayama's study, he induced persistent atrial fibrillation in dogs and kept the dogs in atrial fibrillation by continuous rapid atrial pacing. If you give sham stimulation and the 0.25 stimulation, there's very little effect on left ventricular ejection fraction. But if you give 3.25 milliamp stimulation, the heart rate is better controlled and the ejection fraction increases back towards normal. So this is a finding that supports my statement that I think in the previous neuromodulation trial, the companies, the people who performed the trial should not have excluded atrial fibrillation from recruitment. Atrial fibrillation patients actually might respond to neuromodulation the best by controlling the ventricular rate during atrial fibrillation. This is the LV ejection fraction. You can see 3.5 milliamp has a much better ejection fraction than Sheng. And also, there's no difference to him between male, which is black, and the female, which is red. Now, do we have any data on human patients? We have one. As I reported previously, that patients with refractory seizure disorder have left cervical vagal nerve stimulator implanted. So we have, at the time, I was in Indiana University, and there was a special unit called the video EEG unit, and they take the patient off the anti-seizure drugs and monitor them in an intensive care unit and observe their seizure disorders while having all these sensors on the body. And that's a common standard routine care, and that leads to the change of medication in the future. What we did is we just put the electrodes on the patient to record the skin sympathetic nerve activity. So we have 26 patients drug-resistant epilepsy, 6 had the vagal nerve stimulator implanted, and 20 without vagal nerve stimulator. These are the control group. They all have seizure, and most of them are young people. Vagal nerve stimulation has an on time of 30 seconds, off time 158 seconds, with output of 1.9 milliamp and 24 hertz. This is something that I also want to emphasize, is that the effects of vagal nerve stimulation depends on the off time. Most of the time, patients are not stimulated. They just been stimulated intermittently. This is called the after effect of the vagal nerve stimulation. So again, vagal nerve stimulation is not the mechanism of vagal nerve stimulation is not at parasympathetic activation by the vagus nerve. If that is the case, then vagal nerve stimulation has to be on all the time. But the fact is, vagal nerve stimulator is turned on only 30 seconds, and it has the effect of controlling seizure for the rest 158 seconds, suggest that it causes remodeling somewhere. So this is a human data effect of vagal nerve stimulation on skin sympathetic nerve activity. You can see that at the baseline, when the patient, during that 158 hours, when the patient was not being stimulated, there is a correlation between the subcutaneous nerve activity and heart rate. So when there's a burst of subcutaneous nerve activity, there is a corresponding burst of the sinus heart rate. However, when vagal nerve stimulation happened to come on during the course of recording, the subcutaneous nerve activity was interrupted. It takes a while to return. But so what is the effect of vagal nerve stimulation on the overall nerve activity? So we plotted, we selected 1 hour in the morning when the sympathetic nerve activity is strongest. And we plotted them over here. You can see that then we determined we will plot every hour over a 24-hour period for control group and VNS group, and then we collect them. It turned out that the control group has a higher skin sympathetic nerve activity than the patients with VNS, implying that vagal nerve stimulation has significantly reduced the skin sympathetic nerve activity. This again suggests that the vagal nerve stimulation has remodeled the stellate ganglion. Our most recent effort was to try to make the recording of the skin sympathetic nerve activity easier, and that was just published last couple of weeks ago. We have been using the Power Lab system to record the skin sympathetic nerve activity in dogs and humans. We subsequently discovered this ME6000, which can record skin sympathetic nerve activity with a sampling rate of 10,000. Recently, we discovered this little device which can record the sample at 1,000 per second. This is very unusual for Holter monitoring device because they only sample mostly at less than 500 hertz. So with 1,000 hertz sampling rate, we look at the comparison between the ME6000, which is 10,000 per second sampling rate, and the Pharos, which is the small ECG monitor, which samples at 1,000 sampling rate. We compare them and they actually track each other, although their amplitude of the smaller device with less sampling rate is smaller than the standard ME6000 recording. But Pharos recording from 0.8 to 1.6 microvolt is tracking the ME6000 recording. The amplitude is higher, and they have good correlation. Their frequency spectrum correspond to each other, power density very similar. So we have decided that going forward, we're going to use this Pharos recorder for human sympathetic nerve recording on the skin. And that facilitates a lot of research work because it's just very convenient that you can record the nerve activity using that small device. So the neuromodulation study continues. The other fundamental mechanism of that we can use to cause neuromodulation is based on this knowledge that axonal damage and the die-impact degeneration can change the nerve structure. So this is a cartoon about some neural remodeling. I'm sorry. So here's an axon, two neurons, and here are the end organ. And the neurons obviously innervate various end organ. But if you have the need to ask a neuron to remodel, you can use a physiological mechanism to dissolve the axons, and the axon will reconnect through regrowth. Now, if you, on the other hand, if you have the damage for any reason of the axon, it can also cause so-called die-impact degeneration. That is, you eliminate the axon, disconnect the axon from its end organ, the neuron will die also. So there are two possibilities. One is nerve sprouting, reconnects to different parts. And the other one is simply die-impact degeneration that kills the neuron. So there is a popular procedure, and a lot of people doing research on this, on renal denervation. You have to remember that the hypertension has been a human disease for long, long periods of time. Before the occurrence, availability of anti-hypertensive medications, there are already patients coming into the emergency room with hypertensive emergency. That is blood pressure over 250 or 200, and the patient's about to die and stroke because of high blood pressure. They discovered that one effective way to control those hypertension is go to the kidney and looking for the nerves and take the nerve out. So the hypothesis is that if you take the nerve out from the kidney, you will be able to control hypertension. So here's a renal denervation. Obviously, that didn't work in the clinical trial, but the effects of renal denervation has been used in arrhythmia control. So we did a study of renal denervation in normal dogs, where Dr. Tsai put a catheter into the renal artery. Here's the angio. He then put an ablation catheter and burned the renal artery. And then at the end, redo the angio. Actually, there is no change, no stenosis of the nerve. But after he burned inside the renal artery, there was a significant renal artery damage. Here's the nerve sprouting. Here's the normal media, and here's injured media. On the, I'm sorry. On the right side is a traumatic neointima over here. And if you look at the nerve sprouting area at the progressively increased magnification and use tyrosine hydroxylase staining, you can see this trauma to the nerve structure has created cardiac nerve sprouting and sympathetic hyperinnervation. There are more nerves coming up. However, by damaging the axon, it is also possible to cause retrograde cell death. So we looked at the stellate ganglion, which, as I said previously, does innervate a lot of places in the body, including the renal artery. And you can see the stellate ganglion has these very sick cells. The cells actually is dead. Cytoplasm separates from the surrounding connective tissue. All these are dead cells. And we have plenty of evidence to show that there are stellate ganglion remodeling. This is a tunnel staining, which shows the stains positive for the fragmented DNA. So when tunnel staining is positive, the cell is dead. So there are plenty of dead cells in the stellate ganglion. What we did not expect to find is that there are also dead cells in the brainstem. So here is a positive tunnel stain of the brainstem cell. You can see they are also very active growth, the GFAP staining. GFAP stains the glial cells. So there are increased glial cell and there are neuronal cell deaths. And on the right side over here, there is hardly any finding. So there was a very selective changes, neuromodulation in the brainstem as well. So in these dogs, the stellate ganglion nerve activity reduced, and atrial tachycardia is also reduced. So based on these dog studies, it is possible to use renal denervation to control human arrhythmia by reducing the sympathetic output. Now, there is also significant change in the brainstem after renal denervation. And this is the 18F2 this 18F FTG uptake. Well, the study was done by doing a PET scan, positron emission tomography, and MRI, magnetic resonance imaging separately, and they merge these together. MRI does the background structure, and the PET imaging does this, the 18F FTG. You can see there was a significant change in minus. This scale is a minus, indicating that there was a significant differences, and there was reduced the glucose uptake in the brainstem. Another way to cut the axon is simply open the heart and do the GP ablation. GP is the ganglionic plexi, which are the nerve structure in the heart. And Dr. Zhao, who's my postdoc, who happened to be a neurosurgeon, loved to do that surgery, take out these fat pad, completely taking out the fat pad, and observe what happens to the rapid atrial pacing. And after a rapid atrial pacing, the dogs should have intermittent atrial arrhythmia. But after you take out this fat pad, there is no atrial arrhythmia. And the same thing, if you do look at the stellate ganglion, there are many dead cells in there. So when you cut out the nerves inside the heart without touching the stellate ganglion, several weeks later, you will find that there's a stellate ganglion remodeling, most likely related to die-back degeneration of the neurons. So with that knowledge, so what are the human studies? Does the human study support the idea that neuromodulation can be used for arrhythmia control? Well, the first human study, as I mentioned, was done in 1971, where Dr. Arthur Moss took one patient to the operating room. The patient has a long QT syndrome. You can see how long the QT interval is on the 2. And after he injected some lidocaine into the left stellate ganglion, the QT interval shortens. So what he did is took out the left stellate ganglion in surgery. Dr. McDonald is a surgeon. And the patient then subsequently has reduced QT interval, and the arrhythmia is well controlled. So this is really a phenomenal case that shows removing the stellate ganglion actually shortens QT interval. And a lot of people have not really realized that is actually the case, that there's a communication between stellate ganglion and the heart, and that controls the QT interval in these patients. So there are a lot of studies on the ganglionic plexus ablation in addition to PV isolation for paroxysmal persistent atrial fibrillation. So as you know that we routinely, there are tens of thousands of patients are going to the lab to perform PV isolation. And this is really to the credit of University of Bordeaux under the leadership of Dr. Michel Hasseguera, Dr. Pierre Ye, at the time in the 1990s, that they took out they burned in the pulmonary vein, and they found that it can inhibit paroxysmal atrial fibrillation. This is the single most commonly performed EP procedures throughout the world is AF ablation. But in addition to PV isolation, several investigators looked at the efficacy of additional ablation of the GP, and they identified the GP by anatomical means or by rapid stimulation. And they found that with additional ablation of the GP, the patients fare better in terms of the recurrence rate. Now, this is another study of neuromodulation, effect of renal denervation and catheter ablation versus catheter ablation alone on atrial fibrillation recurrence among patients with paroxysmal atrial fibrillation and hypertension. This is done by Dr. Jonathan Steinberg of New York. They randomized quite a few patients, 392, into PV isolation plus renal denervation or PV isolation alone. So this is what happens to them. This is a recurrence of atrial fibrillation, flutter, or tachycardia of any sort. You can see PV isolation plus renal denervation has a lower recurrence rate during 1 year follow-up than pulmonary vein isolation. So that was a statistically significant difference. So this is a very interesting finding, showing that renal denervation could be additional benefit, provide additional benefit to PV isolation. There is a very curious study about long-term suppression of atrial fibrillation by botulinum toxin or Botox injection into the epicardial fat pads in patients undergoing cardiac surgery. 3-year follow-up, a randomized study that was published in Heart Rhythm last year. This is an international study from Russia as a lead. They did 78 patients with a history for CABG and a history of paroxysmal atrial fibrillation. They randomized them. One group got a Botox injection into epicardial fat, the other got a placebo. They published a short-term effect, but now they published a 3-year effect. It turned out after 3 years, there was a significant benefit of the cumulative instance of rate tachyarrhythmia, of atrial arrhythmia, in which the Botox injection significantly reduces the incidence of arrhythmia as compared to using placebo injection during the surgery. So this is also a study that caused a lot of excitement in the field of electrophysiology. So I've taken about 48 minutes of your time. For the last 2 minutes, I just want to go over this for your take-home message. One is that the rapid stimulation of the nerves causes intracellular calcium accumulation and neuronal cell death. So this is one mechanism of neuromodulation that you can use to remodel the nerves. Is simply do stimulation with the axon. If you stimulate axon, then the nerve cell itself would have too much calcium inside, and they eventually die. And not only that cell die, but the death signal of the cells will transmit to other neuronal cells through these the mechanism that has previously been discovered, that there is a propagation of the death signal. There's a term for it, it's called transneuronal degeneration. So you cause the cell death in some cell, the death signal will propagate, and a bunch of the cells will die. The other approach is axonal damage. Axonal damage can be followed by Diamond-Back degeneration and neuronal cell death. There has been a debate on how does pulmonary vein isolation work. One reason is obviously there was a vulnerable electrical substrate that you burn out the electrical substrate, the patient no longer have arrhythmia. But there is also another school of thought is that because you damage the nerve over there, you also causes the neuroremodeling, which then help you decrease the recurrence of arrhythmia. There is a renal denervation, which basically damages the axon near the renal nerve, which causes retrograde cell death as far away as in the stellate ganglion. So that helps control atrial fibrillation. And the Botox injection into the fat pad, I don't have histology of these. I can only assume that there are some effects that kills the cell, which then causes degeneration of stellate ganglion. But I don't have data on the Botox yet. So these are the today's lecture. I hope to get some comments or questions from you. Thank you.